Hi, I'm Dr. David Rubin from the University of Chicago, and welcome to Best of the Day from the Advances in IBD meeting in Hollywood, Florida from December 12th through the 14th. Joining me right now is Dr. Jim Markowitz, who is a professor of pediatrics from the Hofstra North Shore LIJ School of Medicine. Jim, welcome.
Thank you.
So this meeting has really set some records in attendance and in expansion of some of the different topics, and we're going to talk about pediatric IBD right now. Tell me a little bit about what the themes of the meeting have been in the area of pediatrics and inflammatory bowel disease.
Well, for a number of years now, I guess the most outstanding theme is the impact that the biologic therapy has made on the outcomes of our patients. And as we learn more about these therapies and are exposed to some newer agents, I think that there's lots of excitement about the added benefits that our patients are beginning to see.
And just to clarify a bit more, do the pediatric patients that we're taking care of or that you're specifically taking care of have the same options as the adult patients, and what's the limitation currently?
Well, the biggest limitation that we have is the lack of good clinical trial data for children.
Mm-hmm.
Currently we only have one FDA-approved biologic for kids. Most big centers, though, have experience with all the other commercially available products, although the experience is much more traditionally pediatric seat of our pants experience rather than based on good clinical data. So we continue to try to extract lessons from the adult trials until such time as we're able to get clinical trials performed with the help of the corporation.
Which are obviously very important, and the FDA acknowledges that too.
Important is one thing, but it generally means that it's numbers of years after the drugs are commercially available before we get an opportunity to really study them.
So you're a world authority on this, and what should we know about how the pharmacokinetics may be different or safety concerns may be different? Regardless of the trials so far, what can we really know or expect that might be true about the pediatric population with these therapies?
Well, we've learned over the last few years that certainly toxicities may be different. Mm-hmm. And pharmacokinetics for most of the agents that have been studied are not hugely different between children and adults. With minor modifications of dose, we generally can see blood levels and half-lives of drugs that are really very similar to the adult trials. Toxicities, in particular hepatosplenic T-cell lymphoma, has clearly been an issue because of its tendency to develop in younger patients.
Yes.
And that has very significantly impacted the way these drugs are used in pediatrics.
So you were the first author on a landmark study looking at 6-mercaptopurine in Crohn's disease. And there has been discussion among the adult gastroenterologists or the gastros taking care of adults that the thiopurines may not be as effective as we once thought in Crohn's. What's your take on all that?
Well, like any therapy, the longer it's studied, the more you learn about it. The study that you referred to that we did in children was based on initiating treatment with a thiopurine really on the first day after you've made the diagnosis. Mm-hmm. And I think the earlier into the course of disease you get to treat someone, the better of an outcome you're going to have. And in an illness like Crohn's disease, where we really don't know when the illness begins, my ability to diagnose an 8-year-old closer to the onset of his illness is probably much greater than your ability to diagnose it in a 28-year-old.
I would agree with that.
And so we probably see patients at a much earlier stage of inflammation, which gives us a better opportunity to control or a better opportunity to have good outcomes with all of our drugs, not just with the thiopurines. I mean, that said, we've also learned that there's probably more toxicity to the thiopurines than was recognized a few decades ago when that study was done. And the recognition of that toxicity associated at the same time with other options that are probably equally safe or maybe somewhat more safe, and certainly in many respects more efficacious, mm-hmm. has changed treatment paradigms for many pediatricians.
So in general, has the field moved towards using these immunosuppressive and biological therapies earlier in the pediatric population?
Well, the multi-center trial really changed treatment paradigms in the beginning of this, around 2000 when the paper was published. And so now pediatricians are very comfortable with the idea that they can introduce immunomodulatory therapies very early in the course. What's changing now is the recognition that maybe biologics should be taking that role. That remains a very open-ended and difficult decision for many pediatric gastroenterologists. The toxicity of the drugs that we're talking about now have changed this illness from one in which there was morbidity but not mortality to now raising questions of mortality, and that gives pause to all the pediatric gastroenterologists.
I'm sure, and that's a difficult discussion to have with parents and with the patients as well. So tell me a little bit more about how you think the emerging information on the microbiome or dietary management may actually be influencing decisions in pediatrics.
Well, there's a tremendous amount of interest among our families about dietary therapies, as I'm sure there must be in your population as well. The problem is that at the moment we still don't have practical dietary therapies for which we have good data to say it really makes much difference. And the problem that we face as pediatricians and parents face in making decisions for their children is that when an adult makes a decision to embark on a specific diet, they've made the decision for themselves and they will stick to it as best they can. When a parent makes that decision for their child, there's almost a guarantee about World War III between what they're allowed to eat, which often leads to children who eat that much more poorly. And because we're struggling with growth and development in all of these kids, that dietary war actually becomes quite counterproductive. So we'd love to have specific dietary therapies that could influence the microbiome and modify immune reactivity. And hopefully we'll have that in the near future, but certainly there's nothing practical that we have right now that will fit that bill.
A related topic has to do with using objective measures of mucosal injury. So on the adult side, we've started doing more scopes and looking for mucosal healing as a marker. And my patients who are trying complementary therapies or exploring dietary management, we often negotiate a chance to take a look before and after they try it. In pediatrics, it's a little more difficult given the challenge of doing interventional procedures on kids. So how are you incorporating any kind of objective or surrogate markers?
Well, for the longest time, we were focused on what the sedimentation rate could tell us. And that evolved to the CRP, and I think for many of us now, the fecal markers are really very, very useful. And being able to get quantitative measures of things like calprotectin really has made a big impact on the way we can monitor patients. The problem sometimes, though, is that we identify kids who clearly have smoldering inflammation in the setting of little, if any, symptoms, and then helping families understand that therapy potentially needs to be changed to change long-term outcomes is difficult. There was a focus of a debate that was held yesterday about the role of mucosal healing or reduction of symptoms as an endpoint. And it is very difficult because even when we sit down with families to have a discussion with them about the long-term implications of the therapeutic decisions we're making now, in many circumstances, parents only hear the potential risks associated with the alternative therapies that might be offered, and the last thing they want to do is initiate treatments that they see as risky. And so our markers of inflammation are influencing the way we think about things. How well they're changing therapeutic management is I think, still an open question.
I suppose that you have that additional marker, which we don't use in adults, which is growth and development.
Absolutely.
And that's a very good surrogate in kids, right?
Yes, it's always been.
Yeah.
And there are lots of patients where really the only symptom of their Crohn's disease is that they're not growing well. that they don't have much of an appetite. That's a very difficult concept for parents to understand because it's not something dramatic. If the kids just eat half a slice of pizza when all their buddies eat 2 slices, the parents recognize that as a little bit different, but have 100 reasons to explain why that is, as opposed to that it's their illness that needs better control.
Yeah, that's very important. In 2014, what do you expect will be 1 or 2 of the new advances for the pediatric population?
Well, there's increasing comfort with the early introduction of the biologics, and I think that trend will continue, especially as we expand the number of agents that are available to us to use. I think that there are clearly some patients, though, that we continue to struggle with as they either, as the durability of their response to the anti-TNFs wanes, or in the group of patients who are primary non-responders. And for them, hopefully some of the newer agents that are hopefully on the verge of approval will be able to trickle down to pediatrics.
So what are some of the agents that we should keep our eyes on?
Well, I think the anti-adhesion therapies are going to be useful. There is a pediatric trial from quite a while ago now with Tisabri, and while we don't have data on some of the newer agents, I expect that once the pharmacokinetics are known so that we can begin to adapt adult experience to pediatrics, that we'll be able to help some patients who currently are really struggling despite the biologics that we have available today.
I think that's important. When you talk to parents about risks and benefits, how do you paint the picture in terms of understanding what's your short-term goal and what's the longer-term benefit, and how do you really go through that? I know that's a challenge.
Well, I think, as Corey Siegel has taught us, it's important to be able to give patients and families a concrete understanding of what risk means, and to talk about absolute risk as well as relative risk. And most parents do understand the concept that they put their children at more risk driving to the office for the consultation than they will probably by an order of magnitude or 2 with any of the therapeutic choices that we might consider. It requires a few extra minutes to help them understand that. But if we can paint the right picture in their minds about what real risk means, most parents, especially in the child who's clearly ill, are willing to accept a fair amount of risk if the payoff is a healthy child. And that's really what all these parents want. There are some that will be paralyzed with fear about toxicity almost no matter what you tell them. But I think they're the minority, and over time, hopefully, as they become more understanding of what the disease process is all about, they can make the hard decisions.
That, and when they see the medicine working, I think their perception may change.
There's no question that I'm sure you see the same thing, that people drag their feet hoping not to go on to something like a biologic, and then like an operation, they come back to you a number of weeks or months later, and their one regret is that they hadn't made that decision to use it sooner.
I would agree with you. This morning's session was about complications of therapies and infections. Do you pre-test for EBV or screen for EBV before you start thiopurines? That comes up a lot now.
We don't.
Yeah, we don't either, but I wanted to hear what you're doing.
And in part because there isn't enough prediction for something like EBV, which is chronic and is going to be there, that it's going to change our management very much. We thankfully do not have any significant problem with EBV-generated lymphomas in the pediatric population. It occurs, but they're really so rare that we get away with being able to initiate treatment irrespective of serologic status. It's more of an issue in the teenagers who get primary infection with EBV. They tend to be the patients who we have the greatest problem with leukopenia associated with thiopurines, and so that requires adjustment of their dose for some period of time. But in general, we don't really screen for much in the way of infectious etiology that's really different than what you do in the adult population.
My last question for you is about epidemiology. Do you think that the incidence of Crohn's is rising? Is that what you're seeing in your practice, or what's your theory about it?
Well, that's difficult to answer. I think
that's why I asked.
I think that in the 70s and 80s, it seemed like the incidence of Crohn's disease in particular was rising. I think overall the incidence of ulcerative colitis in our pediatric population was roughly the same. Mm-hmm. My sense is that maybe certainly in the New York area, at least, which is where I practice, that the incidence of Crohn's disease seems to have plateaued over a period of time. It may be that there are more pediatric specialists now, and so I don't see quite so many because we divvy up the pot a little bit differently. There were parts of the country, though, where clearly there was very little Crohn's disease and ulcerative colitis, and now there seems to be a greater recognition of those cases. Whether that's better diagnosis or more frequent disease is difficult to tell, although I suspect it's more frequent disease.
So it sounds like we're making some progress, and we have a lot to look forward to. And I want to just thank you for being part of this today.
Well, it's a pleasure being here. It's a wonderful conference, and it's nice to be able to participate.
My name is David Rubin, and this is Best of the Day from the Advances in IBD meeting, the National Crohn's and Colitis Foundation of America meeting, and with me has been Professor Jim Markowitz. Thank you for joining us, and stay tuned for the next Best of the Day.